Okay, thank you. The journey from cardiac interventions to vascular therapeutics, and I took a liberty to tell you about my journey. So if you think about a journey, it's an act of traveling from one place to another. The first documented cardiac cath was in 1711 by Hales, who put actually a tube into the right and left ventricles of a horse. Warren Forsman in 1929 did a catheterization on himself, and this is the radiograph showing the catheter was introduced through a vein in the arm and advanced into the right atrium. And of course, he received a lot of ridicule for this procedure, this maneuver, and subsequently he was awarded the Nobel Prize. This table schematically shows some milestones in intervention, and you can see that a lot of things that we take for granted, including access, meaning percutaneous vascular access in the 1950s up into the drug-eluting stent trials of the most recent past. So there are a lot of milestones along the road of cardiac intervention, from the first cardiac cath into the drug-eluting stents. The forced coronary angiogram by Mason Soames. And if you look at this, if you've ever watched that movie Frankenstein, this sort of looks like Frankenstein. So he's in a bunker and he's catheterizing this patient who, this shows the first angiogram, but unfortunately this patient had a asystolic arrest and was briefly resuscitated. And that's sort of how we got started with selective coronary angiography. Clearing arteries, we can see here, and then Melvin Judkins, a student of, or an associate of Dr. Dotter, and got us started on actually intervention in the vasculature. And as was mentioned earlier, Andreas Grunzig, we owe him a great deal of debt as far as the coronary angioplasty is concerned. You got to remember that he actually started off in this whole angioplasty era with doing PTA in a peripheral artery. So he's better known for his coronary angiography and intervention, but started with a peripheral PTA. Spencer King, one of the former presidents of the ACC, said that it takes somebody who can take an idea and then percolate and come up with something that is truly remarkable. We advanced to intravascular stents to prevent occlusions and restenosis. And then finally, as I had mentioned earlier, Cypher, the first in-man drug-eluting stent. Now, in our experience, we're at my institution in 1992, we published a experience from our institution of cardiologists performing peripheral vascular interventions. And this was met with both some enthusiasm from our cardiovascular or cardiology colleagues, and with a fair amount of hate mail from our non-cardiologist colleagues. I think this speaks that we need to have training before we progress from doing cardiac or coronary interventions into the periphery. That training can either be proctored on-the-job training, formalized training, supplemental training, or certificates of added qualification. This is a consensus statement from 1992 talking about performing peripheral interventions, or physicians being trained to do peripheral angioplasty and other percutaneous peripheral vascular interventions. And my colleagues and I in 1999 published this manuscript on training and credentialing of cardiologists in peripheral intervention. That led to a consensus statement on revised guidelines for performance of peripheral interventions that was published in CCI that same year. It's interesting that when you look at the credentialing standards, or what's recommended by the multitude of societies, this is a credentialing standard that shows that if you look at the different societies over on the left-hand side, and then you look at the number of both diagnostic and interventional procedures that are recommended for being able to perform these peripheral interventions, you can see that it's all over the place. So the numbers vary from 0 up to 200 or even more. clinical competency statement was published by a multitude of societies, again, talking about vascular medicine and peripheral interventions. And this is important because for us to be calling ourselves vascular medicine specialists or experts, we have to be able to diagnose and coordinate treatments of all vascular diseases. That means identifying and treating disorders that contribute to vascular disease and understanding a lot of things, including epidemiology, pathology, pathophysiology, the clinical presentation, natural history, and therapeutic options. So things that we've been criticized as cardiologists trying to do, things other than coronary interventions. These were things that were missing from our training programs early on. And then you have to have expertise in the non-vascular or non-invasive vascular lab. You must have an understanding of the indications. That means invasive diagnostic procedures, catheter-based treatments, and even vascular surgery. So just because you perform interventions doesn't mean that you neglect or don't understand when surgery may be more appropriate. And then you have to have expertise in catheter-based interventions, and that requires several layers of skills, including cognitive, technical, clinical, and knowledge-based. Task Force 11 recommended to cardiology training programs what was necessary for our trainees to be considered vascular medicine qualified and to perform peripheral vascular interventions. And this is readily available for you to see, but you can see that the different levels of training and the amount of time that's required, along with the components of the training that are recommended. Carotid artery stenting, probably the most political and most controversial medical therapy ever. This was a clinical competency statement by, again, a multitude of societies with recommendations for training in carotid artery stenting. And this was followed by a manuscript on the management of patients with extracranial carotid disease, again, a multi-society treatise. And it's a note, or it's important to understand that, even with these intersocietal recommendations and agreements, there's still controversy that exists with the training of non-surgeons, non-radiologists, non-cardiologists when we perform procedures other than what we've traditionally been trained for. And I think the debate is ongoing, and whether or not that will be resolved in the duration of my remaining career remains to be seen. I think this slide sort of represents a lot of how we look at medicine, or how some of us respond. And I know nothing about the subject, but I'm happy to give you my expert opinion. Thank you very much.